All right, everyone. My name is Sabrina Bernardo, and I'll be presenting this case presentation titled Consult Dizziness. So our story starts when the otolaryngology service was consulted for dizziness at Corwell Dearborn. Our patient was a 53-year-old male. Our patient reported a 10-year history of intermittent disequilibrium. Now, his episodes lasted anywhere between 1 to 30 minutes, and he currently denies feeling off balance. The patient could not identify any discrete trigger, although he feels like his disequilibrium may be exacerbated by the therapeutic phlebotomy, for which he receives due to polycythemia vera. On review of systems, he did endorse some left-sided aural fullness and tinnitus that clears with popping of his ears. He denies any of these sensations on the right side. He also denies any associated vertigo, hearing loss, otalgia, otorrhea, facial weakness, and headache. And then for cardiovascular, he denies any chest pain, palpitations, and syncope. His medical history is significant for coronary artery disease, GERD, hypertension, hyperlipidemia, and again, polycythemia vera. Surgical history is significant for 4 cardiac stent placements and a right carotid stent. Medications include aspirin, atorvastatin, carvedilol, clopidogrel, ezetimibe, and lisinopril. No allergies, family history is non-contributory, and he smokes 2 packs of cigarettes per day. He denies any alcohol and drug use, and he works as a truck driver. And this was actually a significant point of conversation because his disequilibrium makes him feel very unsafe driving a semi truck on the freeway. He's very scared he's going to hit someone or something bad is going to happen. So, on physical exam, his vitals were largely within normal limits. He was pretty anxious during this conversation, given that he works as a truck driver, as I was saying. And the only significant finding on exam was that there was diffuse tympanosclerosis without any tympanic membrane perforation, and this was greater on the left than the right. However, there was really no other findings, and his labs were also within normal limits. And so the differential diagnosis for dizziness is actually quite broad. We can think about eustachian tube dysfunction in this case because he was describing this popping of his ears and this fullness sensation on the left. We can also think about carotid artery stenosis, perhaps leading to brain hypoperfusion and leading to dizziness that way. We can think about intracranial processes such as a cerebellar mass or a cerebellopontine mass. Lower on the differential, we can think of benign paroxysmal positional vertigo and Meniere's disease. However, this patient's presentation doesn't quite fit those diagnoses. And then we can also consider vestibular neuritis and labyrinthitis. So we worked him up and we got a CTA head and neck, which showed no stenosis. However, his MRI brain did show an enhancing lesion in the right internal auditory canal, measuring 10 by 4 by 4 millimeters. And here's the brain MRI, and this arrow is pointing right towards the mass of the internal auditory canal. It's very easily identified on imaging. And so this leads us to our final diagnosis, which is vestibular schwannoma. Vestibular schwannomas are benign, well-encapsulated, slow-growing nerve sheath tumors composed exclusively of Schwann cells. And actually, 90% of these cases are sporadic. Patients can be asymptomatic, but if they are symptomatic, they can have decreased hearing, tinnitus, and imbalance. And since cranial nerve 8 is in close proximity to cranial nerve 7, the facial nerve, you can actually get some facial nerve palsy in rare circumstances. And so for diagnosis, imaging is preferred, specifically MRI. X-ray is pretty nonspecific. CT is somewhere in the middle in terms of specificity. Treatment, if they're asymptomatic, you can observe them. However, if they are symptomatic, they may benefit from surgery, radiotherapy, or VEGF inhibitor. And there are some rare complications, which include intratumor hemorrhage, and actually large schwannomas can result in transtentorial brain herniation, which can be fatal. However, we're talking large schwannomas like greater than 4 centimeters. So that they have to be very significant in size. And so I just wanted to end on this teaching point because dizziness is a very common patient complaint, especially in the ED or in like outpatient settings. So I wanted to talk about like really the three buckets that we can put dizziness in. First, we have pre-syncope, and this is when patients feel lightheaded or they feel faint or they're about to pass out. And this is most likely due to a cardiovascular disturbance. Next, we have vertigo, and these patients will say the room is spinning and it's really just a false sense of motion. And this is most likely due to vestibular dysfunction. And then lastly, we have disequilibrium, where patients are feeling off balance, unsteady, they're wobbly. This is usually due to a neurological condition. And so asking your patients more about their dizziness and thinking about how they describe it can really help you get a more targeted workup. And so I hope this was helpful. I hope it was interesting. These are my references, and thank you so much for listening.